to one and all. And at the outset, I would like to thank the organizers, especially the Prashi, Dr. Vijay, Dr. Kumar for the invite. I hope I'm audible and my screen is visible.
Yes, sir.
Okay, so I'll be briefly talking about a topic which is not much discussed and it is not in prime time right now, but this is going to be probably the future. So this is basically the association between the circulating tumor DNA burden and the disease burden in patients with ALK positive lung cancer. This was published last year in October in Cancer Journal by Shubha Digumurti et al. So I'll directly start with the topic. So just a brief introduction. We all know that ALK positive NSCLC are around 3 to 5% or maybe 7% of all NSCLC, and being despite of a very nice and durable initial response, most patients will develop resistance and they will develop resistance to all the potent and selective ALK target inhibitors. So in these cases, when the patient progresses, we do biopsy, which has provided an important insight about the molecular resistance mechanism. And but now recently we know that repeated biopsies are not welcome by all the patients, so we have to sort out to something different. So recently, the plasma genotyping has gained acceptance, and it is becoming more and more available and studied. So the important part is it's non-invasive, has a favorable turnaround time, and it actually has a better representation than a single-site biopsy. So there have been many previous studies which have demonstrated the diagnostic and clinical relevance of plasma genotyping in this setting, but mainly it has found the detection. It has helped in detection of the resistant evolving molecular landscape, some site-specific factors, and of course the intratumoral heterogeneity. But this study have been largely the studies which have been done in the past have been largely descriptive. They are not rigorously quantified the disease burden, and they have primarily focused on patients with isolated CNS and intrathoracic disease. The current study has actually shown something different, so that's what I'm going to discuss. This is done in Massachusetts General Hospital, Boston, the NCI Energy Oncology Protocol. So they started with almost 119 patients, 119 samples in those patients who have relapsed progressive disease on second or third generation TKI. Out of that, 22 patients were excluded, and finally they had 97 samples of plasma from 75 patients. So these were all patients with who have progressed, who have disease recurrence while they were on second or third generation TKI. The plasma analysis was done within 28 days of the disease progression, as documented on the imaging studies. This was a retrospective study done from March 2016 to March 2019 over a period of 3 years, and it also showed the demographic and clinical pathological features. The disease burden was evaluated with the CT, MRI, and PET. So I'll just briefly talk about the imaging analysis, which is very important when we see the disease burden. So the estimation was done either quantitative, both quantitative and semi-quantitative measures. The typical RESIST criteria 1.1 is the sum of diameters and sum of the areas. And there was a volumetric assessment done to see the intrathoracic, extrathoracic, and overall disease pattern. Semi-quantitative analysis showed the organ involvement score, which is a little unique in this study, and organ category score. So this was correlated with the plasma analysis with the mutation with the highest allelic frequency value, and also included maximum AF and maximum ALK AF analysis. Sorry. So the demographic and the clinical features showed that most of them were non-smokers, as we know that most ALK patients are non-smokers. Hardly anybody had family history. More patients were white race, and an average of 8 days of the time to imaging from the plasma genotyping. Now we come to the results basically, and the different measures of the circulating DNA and their association with the disease location was seen, and correlation appeared largely driven by the ALK mutation AF, which demonstrated significantly higher AF in patients with extrathoracic disease burden. Mind you, this is not intrathoracic and not CNS related; it is extrathoracic burden. Again, the correlation, this table shows the correlation between the overall disease burden and the individual organ involvement with maximum plasma and maximum ALK AF frequencies. And what it demonstrated that the max AF correlated with the burden of the skeletal, hepatic, and adrenal. So these are the three extra thoracic, extra CNS sites which correlated to the maximum AF. The organ involvement score and the organ category score again correlated with the max AF. This shows the correlation between organ overall disease burden and individual organ involvement with ALK and non-ALK alteration, and it demonstrated that ALK fusion AF did not correlate with either extrathoracic or intrathoracic volume. This is the first picture demonstrate that intrathoracic C, the disease is increasing from A to B in last 11 months, but there has not been much difference in the ALK fusion AF, max ALK mutation or max AF. Whereas extrathoracic, the involvement from C to D, progression from C to D in the adrenal mat has shown that over a period of 8 months, the ALK fusion, max AF, mutation AF, and max AF, everything is increasing. Correlation between the isolated intrathoracic and extrathoracic tumor burden and the ctDNA. Again, the first picture shows that the CT scan of the patient having extensive disease, which is extrathoracic, mainly in the liver and bone. It is correlating with high AF, and patients with intrathoracic burden only the AF is not much high. So I'll come to the key summary of this publication. There is a significant correlation between the circulating DNA burden and the disease burden as assessed by the RECIST volumetric analysis and quantitative organ-specific metastasis. There is again a significant correlation which was noted between the presence and increasing number of organ-specific metastasis and the overall quantity of circulating DNA. The circulating DNA max allele frequency and estimate percentage of tumor DNA. This was the highest for the patient with great extrathoracic or extensive extrathoracic disease. Brain metastasis against our usual norms. The brain metastasis burden was actually not found to be predictive with the circulating DNA burden. Intrathoracic disease again was not showing a correlation with the circulating DNA burden. The greatest correlation existed between extrathoracic extracranial tumor burden and the ctDNA, suggesting that there is a biological basis for interpatient as well as intrapatient, that is temporal correlation also, which is different in circulating DNA yield. So in overall, in a patient with ALK positive lung cancer, the maximum plasma alteration AF and the max ALK AF correlates with the extrathoracic burden of the disease, and they are more predictive tumor marker burden compared with the ALK fusion AF alone. So my take on this is that this is not used in the prime time, but this is soon going to become the reality in the future, because in last 1 year after this publication, there have been 3-4 publications which have included this in their either fully or in partially into their practice, into their study. So thank you from the Thangam team, and thank you for the patient listening.
Thank you, sir. Next.